Hey guys, I am going to go ahead and pre-record my lecture for gastrointestinal and then genital urinary chapters that we were supposed to cover for tomorrow, but since classes get canceled now due to inclement weather, you get to see me in my apartment once again. I am going to post the gastrointestinal. Of course, I'm going to send out a Moodle, so you guys read through that thoroughly. You're going to have an assignment that's going to be associated with the GU chapter, just to kind of supplement what the activities that we would do in class. So make sure that you know what the assignment is going to be. Make sure you understand it. If you have any questions, you know you can message me. That assignment will be due on Sunday at 5 p.m. on Valentine's Day. So make sure that you get that done, get it submitted onto Moodle. There'll be a section, it'll be called GI medication GI medication pediatric something. So anyways, it is going to be a list of GI medications that I want you guys to know. I want you guys to get them embedded into your brain. Anyways, we'll go ahead and get started. Let me share my screen so that we can get this PowerPoint started. I am going to also update the PowerPoint that is on the Moodle. I did make some changes. I am going to go off of the PowerPoint. So meaning not following the PowerPoint. So make sure you take really good notes. I'm going to skip over the anatomy and the physiology of the gastrointestinal system in children. Basically, just know that the anatomy of our children, our faces are so much squishier and squished together. So our mouth is closer to our nose, which is closer to our ears. Our esophagus is much smaller when we're little tiny humans. So just know that that can affect the GI system in a big way for kiddos. So they've got a higher incidences of GI issues, diarrhea, vomiting. I mean, every kid we know of in the entire world has vomited, and they always have diarrhea, and they always have some kind of reflux or spitting up or things like that. All that is because of the way that their bodies anatomy wise are sitting. So just keep that in mind. Know that it does mention fluid balance and losses. Fluid balance on children are so, it could change in a second. They could be fine, they could be doing great, and they could have 3 episodes of diarrhea and vomit one time, and then all of a sudden they're in moderate dehydration. So their fluid balance is so fragile, and we just need to make sure that we're constantly assessing the hydration status of our kiddos, even when we're doing our physical assessments, and especially when they're in the hospital, because we're making a change to their routine. So there are different laboratory and diagnostic tests for us to, that I want you guys to know. Look them over. You know that any GI areas, it's the largest area in the stomach whenever we're assessing. Know that there's abdominal ultrasounds that we do. We can not only for the abdominal ultrasounds are we looking for the GI tract, but we're also looking at the liver, and we're looking at the biliary system. We can look at the stomach. We can look at so many different things with just using an ultrasound, and it's a very non-invasive procedure. So it's not going to really harm the patient unless they have severe abdominal pain and they have to kind of get in deeper with that ultrasound. It's pretty non-invasive. Barium swallow with a small bowel series, that is a little bit more invasive. Barium is a contrast. So the child is going to be asked to drink this however much the dose is for the barium. That barium is radiopaque, so meaning when we take x-rays, we're going to be able to see that barium within the GI system. So they'll take a series of pictures. They'll have the child come in, they'll drink the barium, then they'll wait about 30 minutes usually until that barium can get into that small bowel, and then they'll take multiple x-rays so that they can kind of see if there's any blockages, if there's any leaking of the small bowel. They may even go into the larger intestines too, so that test will be much longer. Typically the kid just has to lay there. It's hard for them to sit still. but usually the parents are allowed in there whenever they do that. We can do some blood work, a ton of different things that we can do. Of course, electrolytes, amylase and lipase, that's going to be our pancreatic function test. So we're going to be able to see how our pancreas is working. Are those digestive enzymes moving? Are how are the electrolytes balancing out? What's being released more than others? Are we digesting correctly? Are we losing too many electrolytes? What's going on with the patient? We can look at that with the blood work. An esophageal mammometry, or basically what they're going to do is they're going to take a tube and they're going to go down and test the actual pH level of the esophagus. This is going to test for GERD. An endoscopy, of course, that's a scope that either goes down the throat and they can visualize the inside lining of the stomach, or they can go in through the rectum, visualize the lining of the large intestine. They can also do a hemocult, a stool sample culture. We need to, when we have excessive diarrhea, we need to be able to figure out the problem. It's not always just gastritis, and we'll talk about that here in a little bit. Sometimes it could be a viral, it could be a rotavirus, it could be a bacterial infection, it could be E. coli, excessive E. coli, it could be numerous things, and we can get that by getting a stool sample. It's important for us not only to do a stool sample to identify the bacteria or the organism that is taking over our GI system for those kids, but we also want to make sure that there's no blood associated with it, because there are several different diseases that I will talk about that could include some bleeding in the stool. So we need to know that there's not going to be any blood loss. A HydaScan, that's a hepatobiliary scan. Basically, that's going to check out the function of the gallbladder. It's nuclear medicine. So basically they're going to put nuclear medicine into the child, and that nuclear medicine attaches to those, basically the gallbladder cells. And then they take an image, let you lay down, and basically that radioactive activity, if it spikes up real bright colors, then you know that there's a disease of that gallbladder, and the gallbladder is no longer good. Like I mentioned earlier, you can also do an ultrasound of the gallbladder. You want to make sure that you get an ultrasound first before you do a HydaScan to check for any stones. Sorry, my mom is calling me. To check for any stones first, and then they can continue on with the HydaScan. Usually you have to be NPO for the HydaScan, so nothing to eat or drink past midnight. And then for the ultrasound, typically they might have them NPO depending on what they're doing the ultrasound for. And of course, they'll need to do a bowel cleanse for a colonoscopy, and you'll need to be NPO for the endoscopy. A liver biopsy can be done if they suspect any kind of hepatitis or any cirrhosis of the liver. And then you could do a lactose tolerance test. They can do a urea breath test. Basically, they just kind of see how much urea is left over. It can cause basically, it's just a thing you blow into, and it just says, okay, you're lactose intolerant. And basically, they can check to see that urea within that breath. All right, so let's talk about, I have the stool collection techniques set up. I'm gonna talk about that really quickly, but before that, or right after that, I'm gonna go into some of those GI disorders that can cause diarrhea. So when we're collecting for our stool samples, they don't have to be sterile. Obviously, our stool is not sterile. We can use a tongue blade to scrape the specimen off if the patient is wearing diapers. Seems to be the easiest way. It seems like when they start getting to be a toddler age, adolescent age, we're having to have them catch it just like an adult patient in a hat, and it can be a little bit uncomfortable. If they're having if the infant is having a lot of runny stools, you can actually use a urine collection bag specimen. I find that that's way easier. You can just attach it to the outer portion of their bottom. And if they're having liquid stool, it just goes in there, and then you can take that sample, put it in a collection cup, and then label it correctly and take it down to the lab. For an older child, you want to make sure, just like we do with adults, they have to pee first before they give a stool sample. And because we don't want to mix the urine with the stool, because that can definitely contaminate the sample, and it won't be accurate as far as the reading. So pee first, and then put the maybe a hat down there and try to collect it that way. But if it's mixed with urine, dump it. You'll have to wait. If we have, we can also do a bedpan. If we do have a child that is bedridden, we want to make sure the bedpan is at least clean. It doesn't have to be sterile, like I said, but we want it clean, free from any previous debris. And then we really want to make sure that we reiterate, we do not want that urine to contaminate that specimen. It will not be accurate, and the information that we're going to retrieve from that stool sample is going to be incorrect. Okay, so let's talk about some GI disorders. These are not on a, let me maybe stop share for us. And then that way you can kind of look at me and know that these aren't going to be on the PowerPoint. So we're going to talk about rotavirus. So rotavirus is the most common cause of diarrhea for children. There is a vaccine available. Of course, we know that. We've learned about that in our previous chapters. So there is a rotavirus vaccine. It does not guarantee that they're not going to get rotavirus. Basically, it can prevent them from getting it, or it can just minimize their symptoms if they do get it. It is a transmitted oral fecal route. So playing with toys, somebody went to the bathroom, somebody changed a diaper of a kid, didn't wash their hands in between, then they pick up another child, and that kid's slobbering on their fingers, gnawing on their hands. So it is an oral fecal route. So some of the symptoms which you're going to have, aside from diarrhea, you may have fever, you're going to have loose, watery stools, and they're going to be really, really smelly, like a very distinct smell. It's not like a C. diff smell that we've kind of talked about in the past, but it is a very distinct smell, and it stinks. It just smells really bad. So the second one that we're going to talk about is E. coli. We all know that E. coli is naturally found within our stools. There's so many different routes that you can get E. coli by oral fecal, person to person. You can get it through just objects. It could be maybe in the bathroom and you're washing your hands and there's E. coli on the sink, and you put your hand in your mouth and you didn't wash your hands good enough. So there's several different places that E. coli lives. It lives inside of us naturally too. So you want to really make sure that for E. coli symptoms, you're going to have, it's going to be like a progressive symptoms. So you're going to have watery diarrhea, and then you're going to have abdominal cramping, and then you will have, and you may see bloody diarrhea. So E. coli is one of those virus, or not viruses, bacterial infection that occurs within our GI system that will produce bloody stool. So you need to know that. So it's progressive, watery stools, then a severe abdominal cramping, and then you can get the bloody stools afterwards. So then let's talk about salmonella poisoning. That's another one that is pretty common. Unfortunately, we know that that's due to undercooked meats. There's a cross-contamination that can occur too. So if somebody's cooking and they have raw chicken and they're cutting it, and then they put their fresh veggies on there because they're making a salad, that's cross-contamination. So you want to make sure that foods are cooked to the correct temperature, and that's a lot of the education. So salmonella is primarily undercooked meats. It can also be transmitted from person to person and from pet to person. So that's something that could occur. So if your pet does have an infection of salmonella because you fed them undercooked chicken and now they have salmonella and they're kissing all over your baby, it can be transmitted from pet to person. So signs and symptoms of salmonella poisoning: nausea, vomiting. Remember, E. coli infection didn't have nausea, vomiting with it. The rotavirus didn't have nausea and vomiting with it. So that's kind of a cardinal sign there. So with salmonella poisoning, you've got nausea, vomiting, abdominal cramping, in addition to fever and bloody diarrhea. So make sure you know that. E. vermicularis, which is pinworm. So let's talk about pinworm. It is transmitted. It's a lot of times it's with those infants. So you've got rotavirus that's with those infants, that's transmitted within a daycare, and then you also have pinworms, so which is the E. vermicularis. That's a fecal oral route, so that's the only way that you can get it, from the fecal matter to your mouth. So it is pinworm. So it is varmints within our anal cavity in our lower GI system. You'll have perianal itching, restlessness, and the kids will likely to have insomnia. Restlessness at nighttime. Basically, they're sitting still. And as gross as it sounds, they can kind of feel those little creatures crawling within their bottom. Their poor bottom itches so bad, and sometimes you can visualize those at the anus if you're doing a inspection of the rectum. So treatment for pinworm, just to verify it and make sure that you know if it's pinworm. If you do have a child that is itching their rectum and they are, here, let me show you a picture of that real quick. Share here. That way you guys can see a good picture of some pinworms. Okay, so that is pinworms, and those are on the outside of the rectum, as you can see. That's the outer sphincter of the rectum right there on the anus part of it. You can see those tiny, tiny worms. They can actually feel those crawling. So if you suspect it, what you want to do is you can actually put a piece of tape right before bedtime over their rectum, and then in the morning when they wake up, you can peel that tape back, and if there's pinworms there, then you know that it's pinworms. So this is an actual treatment. We actually do suggest parents to do this if we feel like that there is pinworm. That can then be sent to the lab. Once it's sent to the lab, then we can verify, yes, it's pinworm, and then we can give some treatment for that. So risk factors. Risk factors for all four of these that I talked about: the rotavirus, E. coli, salmonella poisoning, and E. vermicularis, or pinworms. Poor hygiene, poor living conditions, lack of clean water. So those are the three things that we'll find that contribute and are a risk factor for these GI disorders. So let's talk about, let me make sure that we've got, let me stop share, and let me share this screen. All right, share screen, and now we have, just a second. There we go. All right, so now let's talk about common medical treatments. So any GI disorders, anything that causes nausea and vomiting, diarrhea, the number one nursing priority is hydration. Number one, that's the number one nursing intervention. You have to rehydrate. So there are, we also want to talk about nutrition. Used to a long time ago, if they had diarrhea, they would put them on a bowel rest. Well, a bowel rest basically means, so you might hear nurses say that, put them on a bowel rest or a gut rest. If you do that, though, you're not providing any oral hydration, you're not providing any nutrition, and you can actually exacerbate the dehydration status, and their kidney function will start to perform poorer. So, bowel rest, gut rest for diarrhea is no longer a standard. So you're not going to see that. Still, the number one thing to do is rehydrate. Also, a brat diet is not recommended for rehydration. So just know that if you have a dehydrated patient, a brat diet, which is bananas, rice, apples, toast diet, brat, B-R-A-T, bananas, rice, apples, toast. That it is a diet. It is a gut diet, but it's not a diet for rehydration. Okay, I'm going to repeat myself. A brat diet is not a diet for rehydration. Okay, it is for if you have gastritis and you've got an upset stomach and you're nauseated and vomiting, or you're doing a progressive diet after maybe a bowel surgery. So, so just know brat diet is not for rehydration. Okay. Other medical treatments, you can do enemas, bowel preps. We talked about the barium, enemas for constipation. Sometimes with Crohn's disease or ulcerative colitis, our little patients might have to have an ostomy. They might have to have a section of their colon or their small intestine to be cut out, and have a stoma on the outside and have an outward port to defecate. So ostomies are something that is a surgical intervention. And probiotics, there's pro and prebiotics, and we'll talk about that here in a little bit. That basically can support and replace any kind of that good bacteria that's within our gut. And it really, if we just allow our gut to heal itself, a lot of times it can do some amazing things with the help of some medication. So let's talk about oral rehydration. So we've got dehydration. We have a dehydrated child, and you have 3 different types of dehydration. You have a mild dehydration, have a moderate dehydration, and you have a severe dehydration. So let's first talk about mild dehydration and what that child is going to look like. So you're going to have an up to, let me stop share so you know that this is not on a PowerPoint, okay? So we've got mild dehydration is a 5% weight loss, okay? Up to a 5% weight loss. They can have 2%, they can have 3%. A lot of that's water weight. So mild dehydration, 5% weight loss. They'll have a sluggish capillary refill. It might not be past that 4-second point, but it definitely is a little bit more sluggish than the less than 3 seconds when we're assessing for their capillary refill. Another thing, they're going to complain of being thirsty. Okay, so that's mild dehydration. And I would venture out to say that most everybody kind of sits at that mild dehydration level, especially when these kids go from maybe summertime and then they go to school and then they're not sitting around drinking all day. So they might be mildly dehydrated when they go back to school because they only can drink at certain times of the day. So that's sometimes common. So mild dehydration, 5% weight loss, sluggish capillary refill, not past that greater than 4-second point, and they will complain of being thirsty. Moderate dehydration. Let's talk about moderate dehydration is not up to a 9% weight loss. That's pretty significant. They may have tachypnea, so their breaths might be increased. They might have a little bit of increase in respiration rate. Their pulse might slightly be elevated, but not to a concerning point, but they may have a slight increase in their pulse. And they're going to have a decrease maybe in their tear production. So they might still have tears and they might still have a moist mouth, but it's just not as moist as what a normal child would be. All right, so recap. Moderate is a 9% weight loss. Tachypnea, so an increase in their respiration, a slight elevation in their pulse, and then they will have a decrease in tear production. So obviously they're going to be thirsty, complain of thirst too. So keep that in mind. So now let's talk about severe dehydration. So you're going to have a greater than 10% weight loss in the child's baseline. The capillary refill is going to be greater than 4 seconds. They will be tachypnic, so increase in respirations. They're going to be tachycardic, so their pulse rate's going to jump up. They may have orthostatic hypotension, and typically they do. So when they're laying down and then they go to stand up, their blood pressure is going to drop. So blood pressure is going to bottom out. You want to be careful and be cautious because they can actually pass out at this point. So they will have extreme thirst. They may even have a slight headache, complain of a headache. They will have no tears, dry oral mucosa. They might even have cracks within their lips, maybe dry tongue. When you have them stick out your tongue, they're gonna have a dry tongue. Their eye sockets will be sunken in. Their fontanelles, if they're less than 18 months old, because they close by 18 months, they're going to have sunken fontanelles. And then they will have oliguria. So oliguria is very little urine output, or anuria, so no output. So they're definitely not hydrated enough to be producing any urine. So those are some things for severe dehydration. Okay. When a patient is in severe dehydration, we've got to fluid resuscitate. We have got to give them fluids within a safe range, because we don't want to give too much too quickly, but we can, you'll see a physician order, obviously IV access, still encourage oral fluids, and then they may do a small fluid bolus at between 250 and 500 at a time for fluid bolus, and then they may keep that rate to the highest max that for that patient's weight. So that's fluid resuscitation. So what is the best indicator for hydration status? Across the board, we're asking moms, how many wet diapers do you have per day? How many wet diapers does little Sally have in a 24-hour period? 6 to 8 is normal. If they say 2, she's only had 2 today and it's 10 o'clock p.m., then you know that that child is dehydrated. And you can look at those other things to kind of indicate lab values, what are the electrolytes, and then those other symptoms. Are they severely tachycardic? Do they have sunken fontanelles already? Is their mouth, oral mucosa? Then you'll know if it's moderate or severe dehydration. And then the physician will always order the fluid rate for those patients too. So let me share screen again. All right. So when we're doing rehydration for our patients, let's see. I'll get to my page. Okay. So we want to make sure that we do not, the things that we know what are appropriate for oral rehydration. Basically, the number one thing that we can use is Pedialyte or Infolite. For that, we do not want to dilute the formula though. We want to make sure that we are teaching and educating that we are not diluting any of that. It's not going to do any good for the child. We're just going to give more of what is the standard dose for formula, and then Pedialyte, recommended Pedialyte. So not appropriate for oral rehydration: teas, sodas, caffeine containing products. You do not want to give fruit juice at all. And the reason why is fruit juice can actually simulate more diarrhea. So if you've got somebody that's dehydrated because they have diarrhea, you give them fruit juice, guess what? Probably going to have more diarrhea, and it's not going to help any. Soups and broths, we think, oh, it's got fluid in it, but they're high levels of sodium. And what do we know about sodium? Sodium follows water. So when we are increasing our sodium levels within our bloodstream, within our bodies, it's just reabsorbing that water through through our bowels, and it just we lose it all. We just lose all that water. It's not hydrating the cells. The sodium stays outside of the cells, and then we just lose it, and then we're not hydrating our body. We're just losing it. It's just a loss. So let's go to, okay, here is your assignment that I wanted you guys to see. I want you guys to know these. I want you guys to, the assignment that's going to be posted, it will have instructions on it. There's 9 categories. I want you to pick a medication, one medication from each of those 9 ticks there, and you are going to discuss you're going to include the generic name, trade name. You're going to make sure that you include why a patient might be prescribed that. If it's an antibacterial, what kind of bacterial GI disease would they need? If it's a corticosteroid, why would they need a corticosteroid for this GI disorder? So make sure you put in nursing considerations, any warnings. It will be listed on there. I just want you guys to make sure that you do that. It will be due on Valentine's Day by 5 p.m. So make sure that you upload that and get that into us. It'll be just like a regular assignment. The instructions will be on there. But each of those categories, pick one medication, and you're going to include the recommended daily dose per kilogram for our pediatric patients as well. So make sure you don't forget that also. I want to make sure that you know what's the safe dosage range for our kiddos. How many milligrams per kilogram are we going to be giving? All right, so we've got a ton of gastrointestinal disorders that include some risk factors, obviously prematurity, family history, any genetic syndromes. There are some genetic syndromes like cleft palate that definitely fall under that gastrointestinal disorder. Any chronic illnesses, if they've got ulcerative colitis or if they have Crohn's disease. If there was any prenatal factors while the mother was pregnant, if she was on any kind of medications that caused any malformities, any kind of issues for the child itself. If they've been exposed to any infectious agents, obviously, if they have been exposed to the rotavirus, they're going to be at higher risk to get rotavirus. Foreign travel also, I talked about when you go to foreign countries, sometimes their water is different, their foods are different, their foods are cooked differently, so it can increase your risk for salmonella poisoning, and even E. coli too. Some countries don't require as extensive cleaning, and then they may not have good enough water, and you can find maybe E. coli in the water too. So if you've had a patient that maybe recently traveled with their family, of course, COVID is not allowing us to travel. Thank you. Not, but foreign travel can exacerbate that too. Any immune deficiencies or any kind of chronic steroid use, and that just damages the lining of the GI system and can increase the risk for any kind of infection to kind of slide in there. So we know the risk factors for dehydration. We've got diarrhea, vomiting, decreased oral intake, any high fevers. We know when we have high fever, we lose a lot of fluid that way. If you're in diabetic ketoacidosis, a lot of times they have frequent urination with that, and they lose a lot of their water. They don't have those electrolytes needed to fill those cells up, so that can cause dehydration severely. You're always going to see your diabetic patients on some kind of fluids running, and oftentimes with potassium, depending on their potassium levels. Extensive burns. So we know that the protective layer of our skin kind of holds that moisture in. So when that's been open with a burn, we've got an open area, and all of that fluid is just lost. So let's talk about some acute gastrointestinal disorders. I do want to talk about GERD real quickly. Let's see if you can see that. I think you can probably see that. This is colic. Well, let's talk about GERD. So GERD is a gastrointestinal reflux disease. We see that oftentimes in adults, but you're going to see that a lot in our kiddos. Basically, it's a gastric contents. They reflux back into the esophagus, and it can cause mucosal injury due to the acid levels in our stomach. So when we have a shorter esophagus and our stomach is right there and we're being bounced around because we just had a bottle, a lot of times that gastric contents will come back up into our esophagus. So it's very, very common in infants, most common in infants, I will say, but usually it resolves by 1 year old. So it usually resolves by itself, usually by 1 year old. I'm going to plug in my computer real quick because it's going to die. All right. I don't want my computer to die on us because then I have to start all over again. So GERD, so very common in infants. And so let's talk about this. Signs and symptoms for an infant are different than signs and symptoms for a toddler. And so your infant signs and symptoms are going to be spitting up. They're going to be irritable. They maybe cry often. And you'll see kind of a stiffening or an arching of their back. They'll kind of stiff up and arch just because they're having pain. They're having heartburn pain, and it's maybe they might have some of that referred pain in the middle of their back. So they're just trying to get in a comfortable position. So in older children, after the age of 1, they might have heartburn. They might present with a chronic cough, and that's just because that mucosa in our esophagus is damaged, and so it tickles. You got a tickle in your throat all the time. They might even have some difficulty swallowing. So to diagnose GERD, you will need a upper GI or a endoscope. So they'll actually go in and then they can take a sample and see if they can test the esophagus and see if there is high acid levels and the pH levels within the esophagus itself. So they'll do the esophageal pH testing for that to diagnose that. So let's talk about treatment. Let's talk about teaching first. So nursing care, obviously we're going to be doing a lot of teaching. So how are we going to prevent GERD for something that's really common for infants? Well, number one, you want to always feed your kids small, frequent meals, especially those infants. So small, frequent meals. Don't fill them up with a full bottle and then lay them down flat. Okay. So another thing that we can do is we can actually thicken their formula just a little bit if they're to that certain age range, usually about the 3-month mark. You can start thickening up their formula just a little bit with maybe some rice cereal or and that way the fluid is thicker, so it settles down in the stomach. So it's just less likely to kind of slosh back up into the esophagus and damage that esophageal membrane. So basically we're just trying to prevent the reflux from even happening with the thickened formula and the thickened foods. So we want to make sure, here's something really important. You want to keep their head elevated after meals to at least 30 degrees. And you want to do that for at least an hour. So think about this. You get their mamas in there and they feed their babies, and their babies usually fall asleep because their tummies are full. And then you go lay them down flat right after they're eating, and then they don't understand why they spit up all the time. Well, it's because you laid the baby flat after you fed them a full bottle. So small, frequent meals, keep their head elevated at least 30 degrees for at least an hour after mealtime. So you don't want to lay them flat right after they eat. For our toddlers and kiddos, you want to make sure that they're avoiding caffeine products, citrus, any fried foods or spicy foods, And then peppermint can also cause some reflux. So you want to have them avoid that, especially if they very first started chewing gum and they might have the peppermint gum, they might have a little bit of GERD happening. So let's talk about medications for GERD. So you've got your proton pump inhibitors, which is Protonix. That's on one of the lists. So write this down. Or you can, which actually a proton pump inhibitors, how they work, actually, that's one of my favorite drugs to talk about. It actually does exactly what it says it's going to do. It inhibits the proton pumps in our stomach from producing acid. So it inhibits some proton pumps from producing that acid and cause that excess acid within our stomach. So think about it, proton pump inhibitor, proton X. So proton pump X. Proton X. No, 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 no. We don't want those proton pumps to work and cause more acid in the stomach. So it's easy way to remember proton pump inhibitors, proton X. Or H2 receptor antagonists. That's actually a histamine blocker. It's a histamine number 2 blocker. So ranitidine. Oh, I can't say it. Ranitidine. There, said it. So that's another medication that we can use. That works a little bit differently. It blocks the histamine within our stomach, and it keeps that acid from forming in those histamine receptor sites in our stomach. When we think about histamine, well, we'll get into that later. So there is a surgical option for severe GERD. This is when there is zero response to the teaching and zero response to the medication, and you're still having these episodes of GERD. You can have what's called a Nisson fundiplication. In a Nisson fundiplication. So basically the fundus of the stomach is wrapped around the distal portion of the esophagus. So it's kind of tightened. So basically that distal end of the esophagus is open more than it should be. And so it's allowing some of that stomach contents to climb back up the esophagus. So you can actually wrap that fundus of the stomach and wrap it around the distal portion of the esophagus to tighten up that area and to prevent that reflux from forming back into the stomach. So let's talk about pyloric stenosis. Here's on this screen here. Let me pull that up. Look how tiny that little baby is. Okay, so here is, so we know that the pyloric sphincter is between the stomach and the small intestines. So what happens there is there's actually a thickening of that pyloric sphincter and the smooth muscle of that stomach on the inside. So it's a thickening between the stomach and the small intestine, and you can kind of see that there. So basically what it does is it causes an obstruction between the stomach and the small intestine. So baby eats, and there is no way for it to go. Or if it does go, it just kind of drips. It's a slow drip. You might even hear that tinkling sound in the when you're auscultating for the abdominal quadrants when you're auscultating for those bowel sounds. I don't know why I couldn't think that. So it might have that tinkling sound. So you've got signs and symptoms is going to be projectile vomiting. Projectile vomiting. This is exorcism type vomiting that you're going to see. There's a lot of pressure down here in that lower area of the stomach, and it's just going to increase up. And so projectile vomiting, you might even have bloody emesis. Just think about all that food and all that is just sitting there within that acid, and it's going to destroy the lining of that stomach. And so that's going to cause some upper GI stomach bleed. So they might have bloody emesis, and it should be bright red or red emesis. You might even, when palpating, if you're palpating within this area here, right kind of where that stomach is, there might be a olive shaped mass, and it's going to be right in that right upper quadrant. So it'll be a little olive shaped mass, and basically what you're palpating is that stenosis there. And they're going to, you will see peristalsis waves within the abdomen. So if you're, when you're inspecting and you pull up that their gown and you're watching for a little bit, you might see some waves of peristalsis. And that's actually just the body trying to force something out and down the tube like it's supposed to. The body tries to work extra hard for that. Those kiddos are going to be severely malnourished, and you'll see that malnourishment here in this little guy. They will have some failure to thrive, and then they're obviously going to be dehydrated because we know that the stomach really doesn't do a whole lot of reabsorption. That is all in our small and large intestines of that fluid. So the way we diagnose that is with ultrasound. When we do it with an ultrasound, we check that right upper quadrant, and it looks like a sausage shaped mass, and it's right there at that pyloric sphincter area. So a surgical intervention, it will need to be done, and basically it's a pyloromyotomy, and basically they'll just increase that opening in size and just enlarges that opening that way. So let's talk about, I think that is it here. So let's briefly talk about constipation. Let me switch. I want you to, there are some structural anomalies of the gastrointestinal tract. Of course, we talked about pyloric stenosis, hernias that can occur. Please review that in your book. Cleft lip and palate, we're going to talk about that in the GI chapter, but we're also going to talk about that again in our genetic chapter as well. So let's talk about briefly anomalies and complications associated with a cleft lip and palate. So we know that some of the anomalies include heart defects. Mrs. Fairchild talked about that in the cardiac section. I know that when we go into the skeletal system, I believe they talk about cleft lip and cleft palate again, and then it causes some ear malformations, and then there's some genital urinary abnormalities also. So you know what complications when you have a cleft lip, when you're born with a cleft lip, it doesn't just affect your mouth and your GI system. There's a lot of systems that are affected. So one of the main things is when they're very, very newborn and there's a cleft palate, depending on the severity of the cleft itself, there's going to be some feeding difficulties. Obviously, the child isn't going to be able to suck because there's nothing on the roof of their mouth to help with their suction. So a lot of times they'll have small little NG tubes. They may even have to end up getting a PEG tube, feeding tube later on. They'll have trouble the rest of their life typically with their teeth and the spacing of their teeth. They can have many, many cosmetic surgeries, oral, maxillofacial surgeries to correct it. They will have some delayed or altered speech typically, and that's because, again, they don't have the roof of their mouth. We can't speak without the roof of our mouth because that is where we articulate our tongues in the back of our teeth as well. And that's so without that there, they tend to have altered speech or even some speech impediments later on. And they're going to have some inner ear infections as well. Whenever we're talking about reflux and peptic ulcer disease, so keep going on and looking through the cleft lip and cleft palate. And like I said, we'll go over that again in our genetic disorder as well. So here's some chronic GI disorders that you might see with some kiddos. Obviously, we talked about GERD. Peptic ulcer disease is very, very similar to GERD. So a lot of those same treatments are going to tie in together. So constipation. Constipation is a huge one with our kiddos. And there is a table. It is table 42-3. I want you guys to review that table and look at different causes by age. That's very important for you to know. And then that way we know how to treat it. So as far as toddler, 2 to 4 year ages is much different than an adolescent. review that table. I want you to know that table and different causes of pediatric constipation by age. So short bowel syndrome basically is they have a shortened bowel. And so if they have less time for the nutrients and food that they eat to be within the small intestine or the large intestine, it's going to make that stool more liquidy. They'll have chronic diarrhea. Celiac disease, make sure that you know that. I don't think it'll be, you can review it, just review it for the book itself. I can go into another 20 minutes of celiac disease, and for the sake of time, just review celiac disease within the book. Recurrent abdominal pain, that could be multiple different things, multiple different reasons. It could be due to constipation. It could be due to gastritis. It could be due to they could have scar tissue within their abdomen if they've ever had any previous surgeries. It could be appendicitis. And know that abdominal pain is a very vague symptom. So, but that can be a chronic and can become chronic if they can't find a reason for the abdominal pain. So let's talk about failure to thrive and chronic feeding problems. So failure to thrive is whenever the child is not getting the nutrients that they need, and then they start being malnourished. Maybe they're not feeding properly. Maybe they're have chronic GERD and they're spitting up, or they've got some lower abdominal issues within their bowels. So make sure that you're gonna hear failure to thrive quite frequently now in pediatrics, but not only now, but when we go and talk about our newborn care within the next 8 weeks or so. So again, there's that table. It's 42-3. Make sure that you look through causes of constipation by age. I'm going to say that one more time. So there are some hepatobiliary disorders that could be that's a part of our GI system. Pancreatitis, obviously, inflammation of the pancreas. That's when we're going to look for our amylase and lipase results and see that can indicate how the pancreas is functioning. It can also affect our insulin production when we have pancreatitis. So we might have an increase in our finger sticks, or glucose levels might be increased in our labs. Gallbladder disease, I talked about cholecystitis, and then inflammation of the gallbladder, and then that will warrant either having gallstones and then having to have it removed, so a cholecystectomy. Newborn jaundice is the most frequent. And we'll see that's obviously a liver disorder, but liver is part of our GI system. Biliary atresia, I want you to look that up. Hepatitis, look those up. There's different types. You can look those up in your book. There can be some cirrhosis. Once there's cirrhosis in the liver, a lot of times you'll see that portal hypertension, meaning there's just high blood pressure going into the liver. And when you have any kind of high blood pressure in the liver, especially, and in your kidneys, over time that can cause severe liver damage or kidney damage. So know that portal of entry for our arteries that goes in, that filters every single one of our blood cells through the liver. If that has a prolonged high blood pressure or hypertension, it can cause some definite damage. You might see some kiddos that will have some liver transplants as well. So let's talk about signs and symptoms of Crohn's disease and ulcerative colitis. Some of the signs and symptoms are going to be abdominal cramping. A lot of times they'll have nighttime symptoms. So it's kind of like when they're starting to lay flat and they're not moving around anymore. That's when they're going to notice these symptoms more. So they'll be waking up more frequently. They'll have severe abdominal pain. They may feel like they need to go to the bathroom, but they just can't for whatever reason. Remember, ulcerative colitis is inflammation of the colon. So you're going to have an association of fever, With that, it's an infection, so you might even see their white blood count will increase as well. They will have weight loss because the inside lining of the lower and larger intestines is not absorbing those nutrients appropriately. Their growth is going to be delayed, and then obviously they'll have a delayment in their sexual development. So know, just like with our adult patients, kiddos can have a colostomy or an ileostomy placed. Know the difference between the two. Colonoscopy is placed, it's an ostomy placed on the outer portion connected to the colon. An ileostomy is a ostomy within the small bowel itself. Know that the output of both of those are going to look very differently as well. So the output for a colonoscopy or colostomy is going to be much thicker. It's going to be more formed. And for an ileostomy, it's going to look more runnier and maybe have a difference in color. It's not going to be that typical darkness that we see in our colon output. So here is a picture of a little kid. They has got a great looking colored stoma. It's pink. It looks like it's pretty moist. There's some pretty good output. It looks like it is probably an ileostomy based on the color of the output and not a colostomy. So remember stoma. So when we're performing ostomy care, I know that you guys have some of this stuff in your kits in the skills lab, and we will be going through that at some point. So you want to make sure that you are applying it correctly. I will post a video over stoma care in Moodle so that you can watch that, and then we can go over it next week or the week after in Skills Lab. So when we're doing a physical assessment for the GI system, we auscultate first. We want to listen to hyperactive or hypoactive bowel sounds. You can also know that if it's absent bowel sounds, with how many minutes? 4 to 6 minutes. If there's no bowel sounds, then we can document that there is no bowel sounds after 4 to 6 minutes. You can hear tinkling bowel sounds. You might even hear, with tinkling, it's that drip, drip, like in a water faucet. It might even be some echoing there too. So just know that different sounds when you're auscultating for the GI system. For percussion, we're looking and trying to feel if there's a dullness, if there's tympany, if there's distension, if it echoes whenever you beat on it, kind of like a drum. That's what tympany is. Does it sound like it's hollow? Is it flat? Is it dull? Meaning when you kind of press on it, it doesn't really make a sound. And then palpation we want to do last. And we know that when we palpate any things, we know that if there's right lower quadrant pain, it could be appendicitis. So let's see. So there are some concerns for patients that have psychosocial concerns with patients that have chronic GI disorders. So you just want to make sure that you're very cognizant of that, and you take that into consideration, especially when you're caring for the families. You want to be encouraging to the children itself. You don't want them to feel like that this is the end all for them, and you want to make sure that you're giving them the best teaching possible, so that the parents can take care of the child in an outpatient setting, and they're not constantly having to come in for little things that they can do themselves. Like I said, you guys, that's all I have for the GI disorders for our pediatric kids. I'm posting the video today. Today's Wednesday, a day early, and then I'm going to also post the assignments due on Sunday by 5 o'clock. Make sure that you read the instructions very well, and if you guys have any questions at all, you can always send me an email. I will be posting our genital urinary video by hopefully Sunday night. If not, it'll be first thing Monday morning, so that you guys will have that lecture as well. If you guys have any questions, just holler at me. Okay. Thank you.